I want to introduce everybody to my doctor and the way she practices medicine. And I've been seeing her a little over a year, and she does something very different in medicine to everybody else that I'm aware of. It's called direct primary care, DPC for short. A lot of people call it just DPC. It's a different way of billing for healthcare, and in this age of overwhelming expenses for healthcare, I think it's important to share what she's doing and this emerging practice of medicine that's quite different than anything that we've seen in America, at least. And I think it's important for a number of reasons. Insurance costs are just getting insanely out of hand, and I'll give you a little bit of my history so you know where I'm coming from. I've been self-employed since 2005, so quite some time. And back when I first started buying health insurance for myself, an individual, at the time I was married, my wife had good insurance through her work, but they didn't provide health care for anybody in the company, their spouses, oddly. It's just a small company, but everybody that worked there got health insurance for free. And it was really good health care, or a health insurance, and it covered a lot of stuff. But I didn't have coverage, so I had to go buy individual coverage in the marketplace, and I got Blue Cross. Had to wait for a year for open enrollment, which is kind of a pain in the ass. But then, it was very reasonable priced. It had a high deductible. I'm trying to remember what it was. It seemed like it was $5,000 deductible. But I could see a physician, I could see my primary care, and I was covered for catastrophe, and actually I had a couple of catastrophes. So but I'm relatively healthy for my age and my physical condition. I'm just a fat old man, and shockingly, all I really have now is just high blood pressure, which is I've managed quite successfully. Anyway, so 2005, I had health care. I was fairly happy with it. Decent coverage, except high deductible. Anyway, so I was able to see a doctor a couple times a year, get my meds, and covered in case I crashed my motorcycle, which I did. Emergency room covered. Anyway, come what was it, 2009, whenever Obamacare got passed. Well, no, it was later than that. Anyway, Obamacare got passed. He promised all this stuff that never happened. I was actually excited to hear it because I didn't like healthcare as it was set up. I didn't like insurance companies being involved in every bit of my healthcare, making decisions for me. I would just rather pay a doctor right out of my account, and that's eventually what I wound up doing. In the beginning, Obamacare was just a little bit more than what I was paying Blue Cross directly for my insurance in the beginning, and then it just slowly crept up and got to the point where it was $700 a month just for insurance. And it was that point I was just like, I would rather just pay as I go. I wanted to share with you my doctor and how she charges for healthcare. She doesn't bill third parties now. She's has what's called a hybrid practice. She's been practicing medicine for a few years now, so she's got a practice in place, and she has given control of that clinic over to her nurse practitioners. So they run that side of the clinic, and then she takes care of patients. Right now she's seeing only 200 patients. She's gone from 6,000 patients to just 200 patients, and I think that's interesting in itself. But the way she bills her patients is quite extraordinary. It's basically, right now I'm paying $50 a month for all you can eat health care. Doesn't cover catastrophes. I'd still have to pay out of pocket for that, since I'm not carrying health insurance. But you know, conceivably $700 a month, I could stash that in a bank account and, you know, pay for my catastrophe, everything, I guess, probably except maybe cancer or something like that. Conceivably I could pay out of pocket, and you know, especially taking $700 a month out of my check for just to pay an insurance company for the pleasure of having health care. So you can see I'm kind of anti-insurance for pretty much everything, but especially healthcare. I think if you look into the history of insurance and how it relates to healthcare and employers, basically nowadays, if you're not employed, you do not get a paycheck from a company. You do not have health insurance unless you're paying some extraordinary amount. So anyway, I'm getting long-winded. I want Franny to do the talking here. I sat down with her and did a short interview about DPC and how it works and her motivations for doing it, and I just wanted to share this video with you as an option for you guys not to see Franny unless you're in Alabama, but maybe to seek out a DPC professional of your own, just to explore this as an alternative. Because I mean, if you're not sick, if you don't have currently a earth-shattering disease, this is should be a good alternative for you. I mean, if you're 25, 30 years old, you probably only see a doctor, well, I don't know, when I was 25, 30, I think I saw a doctor. I needed to see a doctor maybe once every 5 years or something like that. But you know, doc in the box, that would have worked just fine for me. Back then I had great health care and it was cheap. And anyway, I just wanted to share this interview with Franny and give you some alternatives for health care if that's what you're looking for. And I'll probably have quite a few more videos with Franny coming up with a variety of topics, because she's quite an interesting lady. She's doing all kinds of off-grid stuff and sustainable farming and all kinds of interesting stuff. And you know, we're probably going to be doing a lot of things together in the future, and hopefully you'll get to see those. But check out the DPC video, and if you have any questions or comments, just leave them below, and if I need to make a follow-up video, I'll be glad to do that if I can't answer the questions specifically. But enjoy the video.
Well, I heard about it, now it's been about 4.5 years ago,
okay,
from one of my buddies that I went to medical school with, residency with.
Right.
He was in Mississippi. We were at a party and he was telling us about DPC, and he just introduced us to it by saying, you know, this is a 50-month, he just kind of went on, you know, did the spiel about what it was. And I just was like, oh my gosh, I would love to be able to do that. And that's where it started. I'd never heard of it. It's been around since the mid-90s. Some guy, a couple of guys maybe, like way out in Oregon or Washington or something. They may have been in Texas, I don't remember exactly, but there were a couple of guys who kind of came up with the idea, and it's based on concierge medicine, but it's a lot cheaper. And they came up with the idea in the mid-90s to, you know, as a way to be able to help people who didn't have a lot of money, you know, be able to get to the doctor. So it took, I mean, it's still, there's only maybe 5,000 of us, if that many, in the whole country. There may be more, because it's really every year it increases in size. And I've been doing it 1.5 years now, almost 2 years this summer. And it was like 2 years before that I first heard about it. So it's been about 4 years since I heard about it.
What attracted you to it?
First of all, I tend to be the kind of person, and this probably doesn't sound good, but I tend to be the kind of person who doesn't like to be told what to do. I just don't, you know. And we all, as physicians, we all struggle with insurance companies and Medicare. We all struggle with it because they are expecting more and more and more out of us. The other thing I think that I was really attracted to was being able to go home at the end of the day and not have to work. I mean, I've been working 60 to 80 hours a week now for 30 years, even before medical school, you know, going to college and taking care of kids and all this. And I've loved everything I've done, but I'm like, okay, I'm tired. You know, I love what I do and I want to continue to do it, but I can't keep going the way I'm going. And I started later in life anyway. I was 40 my first year of medical school. So I'm 58 now, and so retirement's only like 7 years away, although I'm probably not going to retire. I want to be able to continue to do it but not kill myself. So that was, I think, one of the things that really attracted me to it. Basically, there's two things, my patients and me. Those two things.
You felt like both of them were getting cheated.
Yes.
The way you were practicing before.
The idea of being able to spend an hour with a patient and not have to worry about it, see 6, 7, 8 patients a day instead of 15 to 30. You know, usually I was seeing 20 to 30 before I got help. I got it down to about 15 a day, and then I kind of had squeezed it down to about 12. But I was still working a lot because I had my nurse practitioners. I had to look at all their work and do my work. You know, I was still always working a lot. And I do a lot of things. You know, I do more, we go to home visits, we do other things that other doctors don't do. I take care of people that nobody else will take care of. We got people who literally cannot get out of their homes. And so we've had an unlicensed home down here that my dad's in. It's unlicensed. Nobody will go to that place and take care of those people. And now home health can't go in there, hospice can't go in there. I said, they got to have care. Somebody's got to take care of them. It's a form of health care where you have to be somewhat responsible for your own, you know, paying your 50 bucks. And I think it's really good for people to do that because they got some skin in the game. So they're willing to take better care of themselves and be a partner, you know, with the doctor. You know, basically, it's not 100% health care because the hospital's not covered, specialists aren't covered. You know, they still have to pay for those visits, but as a family physician, I can do a lot of that for people. Can't do everything. You know, I can't do nephrology, you know, dialysis. I can't do cardiac caths. I can't do, you know, orthopedics, you know, we've even been taught to put casts on, but nobody does that anymore. But, you know, there's a few things I can't do, but I can really help people a lot and save them money, but still take really good care of them and give them good care. So, you know, it's not a short, simple answer to say, you know, you do pay $50 a month, you can come as many times in a month as you want for that $50, get plenty of good service. Pharmacy,
Tell me about
low-cost labs, low-cost pharmacy. Some of our medications are half a cent, a penny a piece. So I can give somebody something called Mobic for like $1.50 for 90 days, you know. There was a medication I gave a 90-day script on. It may have been lisinopril, I don't remember, for like 60 cents. You know, I can't remember exactly. But so we get them really low-cost medications. They are generic. It's all generic. We don't do any, you know, brand names. And then our labs are really inexpensive. A CBC is $3. You know, we can do 4 labs for $19. Basic labs, lipids, A1C, CBC, CMP. Those are just basic labs. Other labs, we do dementia. We teach dementia. We do dementia labs. You know, there's just so much we can do to help on cost. Really can help on cost.
Cost, time you spend with the patient.
Yep.
You want to talk about that?
Their first hour, the first time they come, we don't get to spend as much time on the first visit because we're getting to know them. You know, we go through all their health history and all that, but we literally, most appointments are 1 hour. Now, if they've been established with us for a bit, they don't need quite as much education. I sometimes will get a new patient who is a diabetic and their blood sugars are crazy, and I'll see them 4 times in a month. I've spent 4 hours that patient in a month for 50 bucks. Then it slows down. Then I may see them every 2 or 3 months. It just depends. But sometimes they come in for half an hour. Now, if they have a cold and I'm trying to squeeze people in, they do have to have an appointment. Got to have an appointment. We don't take walk-ins, and we did take walk-ins in our other clinic. because you're with somebody for an hour and they have to sit there. Then you got another person coming right after them in an hour. There's no way to squeeze people in. You've got to have an appointment. So we reiterate that every now and then. We don't have somebody, there's a no-show, so somebody does walk in, we can see them. But we still constantly say, you got to call us, you got to call us. And if they've got a cold, I can see them and they're done in 5 or 10, 15 minutes. So there's only 2 employees, me and my receptionist. And she's a medical assistant, she can do shots, she can do all the stuff. So there's just 2 of us, that's it.
What 5 categories of people that would be should consider DPC?
So people with no insurance that at least have a job or a little bit of money, income of some sort, $50 a month. The second thing is a lot of people who have very high deductibles. So that's who we take care of a lot. They have $2,000 to $6,000 deductibles. They're paying out for health insurance. They still can't afford to go to the doctor. Medications are high, everything's high. So they come to us. We have lots of people like that. We have people that are self-employed, can't afford to give insurance to themselves or anybody else. They come to us. They have plenty of money, pay for all their services. They really, really like it. And then I have all my folks that are used to me and like me and have always had me. They come from my other clinic and they come see me. Some of the philosophies, everybody's a little different. I have some different philosophies that other people don't have. So they come to me for that and they're willing to pay it. They're willing to give me $50 a month. I have some folks who come to me, another reason is their philosophy. I have some hippie folks that come to me and they want to support this new type of health care. They want to help our healthcare system. So they come to me, even though they don't need to, but they want to support it because they want DPC to get bigger. So there's those types of folks too. I have people driving 2 hours from Tuscaloosa who come see me, that heard about me, and heard. I've got some folks who are coming to me because we do dementia. We've just recently started doing that since last summer, and Buddy, there's so many folks that have lots of dementia problems, so they'd rather come to me. I have the knowledge, and my nurse practitioners don't, so they want to come to me. And I help them with dementia. And that's a really big problem.
Anybody else? 2 more people?
Types of people?
Types of people that would...
Diabetics, because I teach a ton about diabetes. Okay. I teach way more about diabetes than almost any physician around. So a lot of, because I help people get off their medicines. So I've helped a lot of people get off medications. And obesity, because I really help people with obesity.
So anybody that's diabetic or obese?
Yep. Okay. And all that kind of goes together. Yeah, high blood pressure, high cholesterol, diabetes, it's all, and dementia, it's all one syndrome. So, so I help those, I do a lot of education. I think direct primary care is really a wave for the future. And I think we're going to head that way. We have so many issues with our healthcare system, really, really bad issues. A lot of physicians are being faced with taking on risk. Now this is a big topic and I can't really go into it right now, but risk, we're about to be taking on risk with Medicare. Well, if we don't perform like they want us to, they're going to take our money back. And a lot of physicians are going to be really upset with that. All of us would be. And that's coming up in the next 3 years, 2 to 3 to 5 years. And there are going to be a lot of people who want to drop out of Medicare because of that. So we've got to come up with a better system. We've got to come up with a way to do prevention. We've got to come up with a way to help people be healthier and get off medications. So to me, direct primary care is a really good way to help do that.
And you think that that's going to take over medicine eventually?
I don't know if it'll take over, but it will become a big part because it's a good model. And it'll probably, it'll change a little bit here and there. The biggest thing about it that's also really helpful for physicians is you don't have to do so much paperwork. That's what's killing us. It's killing us to do so much paperwork. Now everybody wants big data. They want data, data, data. So it's probably going to morph a little bit so they get more data. Right now they get no data from me in my DPC clinic, none. So it'll morph to where they get their data, but not so much. And they don't require us to do so much, all this extraneous stuff that we can't keep up with. So I think it's really, really a good model.
Hey, if you learned something from this video or know somebody that could use an option for healthcare, please share the link to this video with your friends and family. Or if you're a physician and would like more information about DPC, click the link here, and hopefully I will have some more videos in the future with Dr. Ko. And as always, thanks for watching.